Over 500,000 patients resort to back surgery each year as a solution for severe and debilitating back pain. But in 20% of cases, the surgery fails to relieve all the symptoms. The result is called post-laminectomy or failed back syndrome and is incredibly frustrating to patients and their doctors and their families. The symptoms of post-laminectomy syndrome depend on the cause. You may have pain like you did before surgery or suffer a new injury to the nervous system. The pain may be dull and achy or sharp and stabbing. Some patients develop what is called neuropathic pain, where the spinal nerves become sensitized and very painful to the touch.
It's basically a nerve that's been sensitized over a period of time so that it fires ectopically on its own.
Your first priority is to get an accurate diagnosis. I start with an MRI, but your doctor may order x-rays, EMGs, or special exams. Your medical team may have missed a condition like spinal stenosis as an example. I can't emphasize just how important the right diagnosis is. With that, you can come up with a highly effective treatment plan. Be sure to discuss transdermal therapy with your physician. It may offer an excellent solution, especially for cases involving neuropathic pain.
Transdermal offers is that ability to deliver the medications at the site of the problem, if it's a lower back, and you can combine all the 3 or 4 classes of medications and make them penetrate deeper into the tissues where the actual pain is.
Here's how it works. After injury, white blood cells pour into the injured tissue. In their cell membranes, arachidonic acid is released and metabolized through 2 key enzyme pathways, COX and LOX, which produce powerful immune modulators: PGE2, TNF-alpha, IL-1, TGF-beta, isoprostanes, and thromboxanes. After release from these cells, they bathe the nociceptors, lowering the threshold for firing and increasing pain. On the COX side, diclofenac decreases COX-1 and COX-2 production, which reduces the production of PGE2, the most powerful modulator in the body. Since diclofenac is delivered peripherally, there's little risk of bleeding complications. On the LOX side, pentoxyphylline is a potent inhibitor of TNF-alpha production, a highly inflammatory immune modulator which accelerates all inflammation. The total effect is to sharply decrease the number of modulators produced from both the LOX and COX side and released from white blood cells so that far fewer bathe the nociceptor and the threshold for firing increases as a result. We also saw that inflammation causes the rapid increase of NMDA receptors along the nociceptor, which also lowered the threshold for firing, making the nerve more responsive. The following medications target the NMDA receptor, which slows the calcium influx and prevents depolarization: ketamine, gabapentin, or phenedrine. The use of multiple NMDA receptor blockers has been shown in the laboratory to have a synergistic effect. Now let's look at the overall effect. The pharmacological blockade blocks the production of immune modulators from white blood cells, stimulates the GABA-beta receptor, and blocks the NMDA receptor and sodium channels. Taken together, these increase the threshold for firing, so a much greater stimulus is necessary before the pain receptors discharge. Patients report good relief of pain. Application over the area of the spine that innervates the area is where you want to put it. It's where it hurts the most. When you consider there's a greater concentration of pain receptors in the dorsal root of the spine than where it really hurts, this is an approach that really makes sense. You want a strong rehab program with great physical therapy and regular physical exercise to continue to improve. To learn more about these medications, visit the Transdermal Therapy homepage. Thanks so much for watching.